By the time you can start your screen and start speaking, not an issue.
Yes, sir. I'll just send to you and I'll continue. Sir, I've sent to you.
Yeah, I got it.
I'll just continue. Okay.
Yeah, start speaking. I'll just try to
I'll start, sir. Okay, so common scenario is we see the definition. So seizure is a transient occurrence of signs and symptoms due to abnormal, excessive or synchronous neuronal activity in brain. So what is unprovoked seizure? It means there are no provocating factors simply, but by definition, it is a seizure that occurs in the absence of a potentially responsible clinical condition or occurs in relation to a pre-existing brain lesion or a progressive nervous system disorder that is beyond the time interval recognized for acute symptomatic seizures. That means even the remote symptomatic problems comes under the definition of unprovoked seizures. An acute symptomatic seizure means something that occurs in close temporal association with the acute systemic illness or a brain insult. Example, a hyponatremia.
I mean, can the screen be used?
Yeah.
The screen?
Yeah.
Okay, keep on.
Is it okay now, sir? Can you continue?
Yeah. Okay. Continue.
Yes. Like acute symptomatic seizure occurs secondary to some systemic problem or a brain insult, like a hyponatremia, hypocalcemia, a fever induced like a meningitis, a toxin exposure, or an intracranial bleeding. So epilepsy, ILA in 2017 defined epilepsy as a disorder that has an enduring predisposition to generate epileptic seizures. It means there should be at least occurrence of one epileptic seizure. But the operational definition, there is a slight change only in the operational definition for epilepsy now. At least 2 unprovoked or reflex seizures occurring 24 hours apart. Okay, like this was a previous definition also. 2 unprovoked seizures at least 24 hours apart, we consider it as epilepsy and start treatment with anti-epileptic drugs. But when do we start, even if there is 1 unprovoked or a reflex seizure? Only when there is a probability for further seizures is similar to after occurrence of 2 unprovoked seizures. That's it. Like after 2 unprovoked seizure, the probability or the recurrence is 60%. When this recurrence is similar for 1 unprovoked seizure, then also we have to consider it as epilepsy and start an anti-epileptic drugs. Or we have a diagnosis of a epilepsy syndrome. So epilepsy syndromes is something that has a specific age of onset. They have specific seizure types and progressions. They might have a family history and some typical EEG findings, like we have our childhood absence epilepsy, juvenile myoclonic epilepsy or an absent epilepsy, or BECTS, Dravet's. So there are a lot of epilepsy syndromes. If even such a diagnosis is made after a single unprovoked seizure, then that is also considered as an epilepsy to start anti-epileptic drugs. So this is the new classification, which gives a multi-level classification. There are 4 components. So whenever they present to you with a seizure history, we'll have to first see what is the type of seizure, like whether it is a focal seizure or a generalized seizure, or if not coming under both, we call it as an unknown one. Then after that, you classify it in which type of epilepsy they come under, and then the epilepsy syndromes. Not just with classification, we also have to find the etiology for the seizures also. Like genetic etiology is the most common, like most of our idiopathic epilepsies come under a genetic etiology. And all the others, like structural, can be seen as malformations. Metabolic, not the acute metabolic causes, but rather the inborn errors of metabolism. Immune, for example, your autoimmune encephalitis. Infectious, like a neurocystic sarcosis or a tuberculoma, and not the acute infections. or if even after extensive investigations not able to find the etiology, then it is called as a unknown. Okay, so coming to the clinical approach. So first step is whether the episode is an epileptic seizure or not, because we're only going to get a history. We have not witnessed the seizure. So first we have to see whether it is actually an epileptic seizure or not. Next, what is the cause for the seizure? And depending on that, we should decide what investigations that we are supposed to do. And then very important is whether we should start the child on AEDs or not. And what are the other things that we should consider when treating the child. The first step, what was the episode an epileptic seizure? Okay, this is a consideration because we have a lot of non-epileptic events. For example, most commonly a syncope, or if it is a younger child, we should consider about breath holding spells, which is common. An older child, daydreaming or staring episodes are very common. So we should take a very, very detailed history from the person who has actually witnessed the episode, not just from the parents. Even if the one who has witnessed is a teacher or someone else, we should make an effort to make a call to them and find the actual event that preceded the seizure, during the seizure, and immediately after the seizure. So clinical history is the key. So for diagnosis of seizure, it's only based on history. So immediately prior to the event, if there is any precipitating factors like a light or a sound seizures, and it always occurs when the child is upset and crying, then always think about breath holding spells. And only after a minor blow to the head or to the upper torso, then consider a pallid infantile syncope. This is a common scenario that we can see in the home or even in the schools. No, like when you give a minor blow to the upper part of the body, they suddenly fall. Okay, this is nothing but a syncope episode, and it only occurs in the classroom and not by the in any other scenario. It could be just staring episodes, which is common and goes with ADHD and inattention disorders. And always when standing and preceded by nausea and dizziness, consider vasovagal syncope. And following any psychological stressors, it is also common nowadays. Children, they complain of so much psychological stressors, which we didn't think was there some 20, 30 years back. Okay, like school maladjustment, peer bullying, any quarrels in the parents, and separation anxiety. These are common ones, but many other things also now becomes a stressor, and it is very individualized. Okay, may not be the same for everyone. Always think of psychogenic paroxysmal non-epileptic events. And if it is preceded by prolonged standing, for example, in the school assemblies, in a crowded places, they've not taken their food or unpleasant circumstances, again, syncope. And very, very important to ask about aura. May not be that easy to get in a younger child, but maybe about 5 years, we can get the history related to the aura. Any auditory or visual hallucinations, any feelings like a deja vu or a jamais vu, and any strange smells or a taste. This could be suggestive of a seizure, especially a focal seizures, where such auras are common. And any loss of appetite, nausea, vomiting, or headache occurred before or after the event. Okay, so if it occurs before the event, then we can think of migraine. In GTCS, nausea and vomiting can occur after the event. So these are events. Now, during the event, we'll have to look whether the child was looking pale, cyanotic, or was there any forceful eye or head deviation to one side. So if the child became pale after the during the episode, then it could be just a syncope, okay, any anoxic spells or any cardiogenic cause of syncope. Cyanotic, it could be because of any generalized tonic-clonic seizure. So after the episode, the child turns blue. And forceful eye or head deviation to one side can occur in focal seizure or versa movement. Also notice the limb movements, whether they are unilateral, they are bilateral and synchronous, or was they irregular and thrashing. This is very important, what happened to the eyes and the mouth. Okay, so eyes usually are open in case of generalized seizures, and mouth also you can have deviations to one side. Whereas in psychogenic other cause of syncope, usually the eyes is closed. And what is the patient response to the verbal commands, pinching or any pain stimulus? Okay, so usually a seizure does not stop immediately with any verbal commands or a painful stimulus. We should think of non-epileptic causes. So these are some of the common benign non-epileptic events that usually we confuse with seizures. Sandifer syndrome, like due to a GER, occurs in normal children, but usually common in neurologically abnormal children. There is abnormal tonic posturing within minutes of feeding might be associated with regurgitation of feeds. And benign myoclonus of infancy, usually common in babies like 3 to 15 months, they'll have clusters of this tonic or myoclonic jerks involving the head and the trunk, and usually have a remission within 3 months. And shuddering attacks. So shuddering attacks, how it happens is in babies, they suddenly stop doing anything, like there is a behavioral arrest, and they'll have some shivering movement of the upper body alone in the shoulders and the upper limbs, as if a cold water is being poured on the baby's back. And gratification episodes common, like they'll have some rocking, grunting, and they have pressures on the perineum. And spasmus nutans, okay, very important. Like this again seen in the infants. It's a triad of features. They have paroxysms of torticollis, nystagmoid movements, and head nodding. And hypereplexia. So hypereplexia, again, it's like a startled response, but what happens is there's sudden tonic stiffening of the whole body. Okay, so these are some non-epileptic events. And at the end of the history, our aim is to differentiate these non-epileptic events from the epileptic events. So after the seizures, we'll just see what is any post-ictal state. May not be there in all types of seizures, can be there in generalized tonic-clonic seizures and other seizures. And always look for any focal neurological findings. Okay, that is very, very important to look for the etiology of seizures. Todd's palsy also, if it is present, it's also significant to consider. Another history, so apart from that episode of seizures, we are supposed to ask for history related to the etiology. So any previous illnesses that can be associated. So any remote symptomatic cause that we can find from the past history, like any history of meningitis, any history of birth asphyxia and HIE, and any remote trauma. And development history, of course, our epilepsies are common in children with developmental delay, and a very detailed family history or genetic causes of seizure disorders can run in families. Okay, so after at the end of the history, we are supposed to come to a conclusion of whether it is an epileptic seizures or not. So if it is a seizure episode, then we have to think about what is the cause for the seizure. So even when it is a epilepsy, there are certain causes for epilepsy. 50% is idiopathic, all are genetic causes, and the rest 50% is symptomatic or probably symptomatic. Our absence epilepsies, the Rolandic epilepsy, myoclonic epilepsy. So all these come under the idiopathic causes of epilepsy, and symptomatic will be the structural causes like the malformations, the neurocutaneous syndromes, the vascular malformations, any previous CNS infections, stroke, trauma, inborn errors of metabolisms, and tumors. So it is this that we can identify by the other investigations. So idiopathics, how do we differentiate whether it could be an idiopathic or a symptomatic cause? So in idiopathic, the development will be normal, the CNS examination will be normal, but in EEG, we can have some typical findings, EEG findings that is actually suggestive of the epilepsy type. Okay, so this is idiopathic. This is what even our case scenario is. Okay, the child will be developmentally normal. Examination can be normal too. And symptomatic types, so there can be developmental delay. CNS examination can be normal, and there can be history of some previous neurological insult, any dysmorphic features or other congenital abnormalities on examination. Okay, so how do we find this etiology of seizures? So what investigations are we supposed to do? The aim of the investigation is to find the etiology and also to determine the recurrence risk. Because in the operational definition of epilepsy, what we saw is if there is one unprovoked seizure, we need to find the recurrence risk. If the recurrence risk is very high, we are going to start them on AEDs. So basic investigations, it depends on history. Rapid point of care glucose is always done. You know, any child who comes with seizure, any changes in the sensorium, we do this. And the other routine investigations like serum electrolytes, calcium, magnesium, complete blood counts, RFT, the LFT, ECG, of course, if there is any pointing towards any cardiogenic syncope, and LP. LP is useful only in the acute symptomatic seizures. In remote symptomatic or other cause of seizures, we can find some non-specific abnormalities in CSF, which may not help in diagnosis and rather increase the confusion about the etiology of seizures. And serum prolactin. So serum prolactin is done to rule out epileptic versus non-epileptic, but practically it's not that useful. The rationale behind the serum prolactin is supposed to increase after a seizure episode, an epileptic seizure episode. But even a normal prolactin does not rule out. It's not elevated and all, and of course we need not do it routinely. And EEG, so EEG is virtually every child with an unexplained seizure or recurrent seizure should have an investigation that we are going to do in this scenario is to first do an EEG or an electroencephalography. Then the utility. So why do we do an EEG is to support the diagnosis of epilepsy or the epilepsy syndrome, determine the type of seizure or the epilepsy, to find out the risk of recurrence, and also while discontinuing the treatment, it was also helpful if we're going to do a repeat EEG at that point of time. Okay, so we're going to do it all by this EEG again has limitations. So a normal EEG does not rule out an epilepsy. Okay, because like even in after extensive investigation, some 30 to 50% may not have a EEG abnormality. Okay, so normal EEG does not rule out epilepsy, and an abnormal EEG does not define an epilepsy, because we've seen even a normal children have abnormal epileptiform discharges. So it should always be a correlation with the history and other investigations, and not just EEG per se should make a diagnosis of epilepsy. And very, very important thing last is interpretation is very, very subjective. It depends on the skill and the experience of the person who interprets the EEG. So how to increase the yield of this EEG? Okay, so one is the timing of EEG. When are we supposed to do this EEG? So highest yield is within the first 24 hours. So child has a seizure. The first 24 hours, if you do, then there is maximum chance of finding abnormalities in the EEG. But one important drawback is there is usually a non-specific post-ictal slowing that is associated in the first 24 to 48 hours. So usually after 3 to 4 days, we can do the EEG. May not have this post-ictal slowing, but we have to do as early as reasonably possible. And how to do this EEG? See, awake and sleep is ideal, at least for 30 minutes. But in smaller children, doing an awake EEG is not possible. It leads to a lot of motion artifacts. They may not cooperate for the investigation at all. And most epileptiform abnormalities, they appear in sleep only. So sedation is not again advisable. As much as possible, we have to allow natural sleep of the child, because even the drugs as such can interfere with the EEG patterns. But if we have to sedate the child is not sleeping at all, very irritable child, very young infant, then the preferred drugs will be triclophos, a melatonin, or a clonidine. So IV midazolam or any other benzodiazepines are not supposed to be given. And next comes the sleep deprivation. So sleep deprivation is supposed to enhance the EEG abnormalities, enhance the picking up of the EEG abnormalities. So, and wake up the child again at 5 o'clock in the morning. I don't think this is practically possible in younger infants. And even the utility of the sleep deprivation is questionable, may not be required in the first EEG. If you're not able to pick up in the first EEG and we are going for serial EEGs to find out the cause, at that time it may be tried, but not that that mandatory to do it every time, even in the first EEG. Repeat EEGs or serial EEGs. So this is again done if we are not able to find out a EEG abnormality first time and we have a suspicion of an epilepsy that will have a typical EEG findings. So when to do this repeat EEG is not well defined. You can do it whenever we want to do it. And the yield increases from, in some studies, the yield increases from 44% to 61% in the second EEG. So when you're doing the second EEG, we can try these modalities like doing a sleep deprivation or the timing of EEGs. Like if you're suspecting a juvenile myoclonic epilepsy, they'll have myoclonic jerks when they wake up in the morning. So you can do it in the morning time. If it is a BECTS, they usually have it in the night when they go to sleep. So you can do it in the night time. Okay, so but even with the serial EEGs, not more than 3 or 4. Okay, so if you're doing 1, 2, or 3 at the maximum, by third, or something you should be able to pick up. If not, you may not be able to pick up how many other times you're going to do, even after doing a serial EEGs or all our modalities to increase the yield. And prolonged EEG, that is a video EEG or an ambulatory EEG, which we can do 24 hours. Okay, can be done in some cases, like pre-surgically they do, or if we sometimes it can help in increasing the yield of EEG. So common EEG patterns, like of course we are not great in interpreting the EEG. We always take the help of neurologists. But when we take an EEG, we have to see two things. One is the background abnormalities that is there, and the next is the epileptic form patterns. Okay, interictal epileptic form patterns are something that is very, very important to make a diagnosis. All the other non-specific EEG abnormalities may or may not help in making a diagnosis. Like in absence seizures, we have 3 Hertz spike and wave discharges that is typically seen. In myoclonic epilepsy, we again have bilateral spike wave and spike patterns, which can be aggravated with photic stimulation. In VECTS, we know we have West syndrome, we have the hypsarrhythmia pattern, multifocal spikes and wave discharges. And Dravet syndrome, they have different types of seizures also, so they can have generalized focal or multifocal discharges. So when we talk about EEG abnormalities, we should understand that abnormal EEGs are found even in normal children. Okay, so in various studies, it has been some 5%, 3.5%, and 6.5%. Okay, so these children, these normal children, had abnormal EEGs, and the common abnormalities that were noted also were centrotemporal spikes and generalized spike and wave discharges. So all these shows that we should take the EEG report with a pinch of salt. Okay, always correlate with the clinical and other investigation. So next important investigation after EEG. So EEG we know it's a must, and what are the precautions we should take to do the EEG and interpret the EEG. Next comes the neuroimaging. So when we take neuroimaging, so whether we are going to do it immediately or after an EEG, and what we are going to do, whether it is a CT or MRI. So we have all these questions. So neuroimaging, 1/3 only. So 1/3 who present with unprovoked seizure usually have some abnormal findings, but in that only 2% are clinically significant in decision making. So urgent neuroimaging, we consider only if there are some new focal neurological findings on examination, like you suspect a stroke or something like that, or when there is a prolonged altered mental status for an event. So it's a child is there in an encephalopathy kind of a state for a longer duration. Okay, so these are the 2 indications where we are supposed to do a urgent neuroimaging. And when it comes to an urgent imaging, of course, I think when taking a CT or MRI, depending on the availability and the time that which we can do CT, like we can do it at any time, even in the morning or in the night. Okay, like, but MRI may not be there always. So I think CT is preferred in urgent neuroimaging. And thinking of the utility of CT, like in the first seizure. Okay, in the first seizure, it means it includes both provoked and unprovoked seizure. So in any first seizure, CT can find some 3 to 5% of acute findings which are clinically significant. But if it is going to be an unprovoked first seizure, only approximately 1% had some urgent findings and 10% had some non-urgent findings. But less than 6 months of age, so this is a special group. In less than 6 months of age, always admission and evaluation is indicated. So they can have a clinically relevant abnormalities 50% of the time on CT scans. So non-urgent MRI brain. So should we do non-urgent MRI brain and all? Like if you have a good history that is suggestive of a seizure type, and EEG is also suggestive of some idiopathic or a genetic seizure, MRI brain is not indicated. We can start the child on AEDs. So it is indicated if we have a localization related epilepsy, like we have a mesial temporal sclerosis, a temporal lobe epilepsy, and consider there is a history of developmental delay. There is focal findings on EEG. So if you want to look up for any focal lesions on the brain, and they have a remote cause for epilepsy syndrome. So any past history, any brain insult, and in children. So any children whose etiology of epilepsy we do not know with investigations before a neuroimaging, we are supposed to do a neuroimaging. Okay, so we have not found any cause for the seizure up to EEG, then always do a MRI brain. Okay, so MRI we know it's definitely better than CT in detecting the brain malformations, the dysplastic lesions, as well as the subtle temporal lobe pathologies. And we should use a standard MRI seizure protocol where we have thin slices of MRI being done. Gadolinium contrast, of course, not routinely indicated. Maybe in tumors they do a gadolinium contrast, but routinely not indicated. And less than 2 years of age, some special sequences are required because we know like problems with myelination and all these factors are there. So less than 2 years, they might require some special sequences. So what are the common findings? So most of our symptomatic and probably symptomatic varieties we can pick up on our MRI. In temporal lobe epilepsy, we can find hippocampal sclerosis, cortical dysplasias, and tumors. So if all these are found, then it means that they can be medically intractable to the treatment. And many studies have shown at least 16% have MRI abnormalities and unprovoked seizures. And if they have an MRI abnormalities, the recurrence risk is high. So NCC and tuberculoma, see most of the guidelines that we're talking till now is from the AAN and other like Western data. Of course, including the Indian studies also. But when it comes to our setting, the Indian setting or the developmental country setting, something that we're supposed to always consider in an unprovoked seizure, especially when the child is looking normal when we see the child, is NCC, very, very common neurocystic psychosis. So it typically a new onset partial or a generalized convulsive seizures that can occur in clusters in an otherwise normal child. It could be a NCC or a tuberculoma. So this necessitates neuroimaging, especially when idiopathic epilepsy syndrome is not established with EEG. Sorry, if idiopathic epilepsy syndrome is not established with EEG, definitely we'll have to do a neuroimaging. In a good history, examination, EEG, MRI, so everything turns out to be normal. We don't have any cause for the seizures and epilepsy. Then these could be the other scenarios like metabolic, genetic, immune-mediated, and neurodegenerative disorders. So investigations for these, of course, we don't do after the first unprovoked seizure, maybe after a repeated seizure, or maybe it should be done in specialized centers. Important area that we're supposed to consider. So definite indications for treatment is a second unprovoked seizure. Of course, we all know second 2 times if the child has unprovoked seizure, then you start AED. And there is a diagnosis of epilepsy syndrome. Again, depends on the recurrence risk. Okay, the risk of recurrence versus the risk of taking chronic medications. So epilepsy syndrome, like a typical history with the first seizure syndrome, 80% they could make diagnosis with the basic investigations like that we could do. Like with history and the clinical details, 47% of the epilepsy syndromes can be diagnosed, and with EEG additional 30%, and with MRI additional 40%. So, but if it is not an epilepsy syndrome and a first seizure, then you think of what is the recurrence risk. That is very, very important. So how to determine this recurrence risk? So it doesn't mean that every child who comes, we do some mathematical calculations and see whether it is more than 60% or not. So it's just with we see whether the risk is high or not from the data that is available with us. That's it. So if after a first unprovoked seizure, only 10% of the children will go on to develop more than 10 episodes of seizures in their lifetime with or without treatment. Okay, if the child is neurologically normal and no acute cause or no neurological illness, 25% has the risk of having another seizure in the next year, and 45% can have a seizure in the next 3 years. So what are the factors that increase the risk of having a second seizure? So when all we should consider better in starting an AED after a first episode is prior neurological insult or a remote symptomatic cause of seizure. So these children, they have a tendency to have a high recurrence. There is epileptiform discharges on EEG, not just an abnormal EEG, but interictal epileptiform discharges on EEG and significant MRI findings, which is suggestive of some cause for epilepsy. The other factors that could increase the recurrence is a focal seizure, having an abnormal neurological examination, a developmental delay, and seizures that start while asleep, because that's a BCTS is amenable to treatment, and family history of epilepsy. So EEG can predict the recurrence risk. Okay, so 10-year risk of seizure recurrence after a single unprovoked seizure with epileptiform abnormalities on EEG is around 76%. But if you see that after 12 months of seizure freedom, then it decreases to 60%. It means the longer they stay seizure free, the less is the chance of recurrence. Okay, so we can predict the initial risk, but after a few years, it is again questionable, the risk of recurrence. So why not allow the child to go and experience a second seizure? Okay, so after a second seizure, we are anyway going to start the therapy, right? So early versus delayed, what is the difference in starting after a first seizure or the second seizure? So studies have shown that after a first seizure, if you start, it definitely reduces the risk of experiencing the second seizure. But on a long term, if you think about the seizure remission or the long-term prognosis of epilepsy, there is no difference. Whether you start after a first seizure or a second seizure, the child being in remission after treatment or the long-term prognosis on the development, there is no difference at all. So if the first seizure is a status or a prolonged seizure, so should we consider that alone as a factor to start on AED? So that again is controversial. Like overall recurrence following a first prolonged seizure was no difference after a first brief seizure, but recurrent seizure was more likely to be prolonged. So first seizure is a status, maybe the second can also be a status, but that doesn't mean that the child will go on to have multiple episodes, okay, just because they experience a status epilepticus. So why not allow the child to have a second seizure? Serious injury is very, very uncommon in children. Sudden unexpected death in epilepsy is again very, very uncommon in children. And restrictions, okay, so restriction is for any other child. So no, any other child, like, when they do a cycling, you ask them to wear a helmet. If they go for swimming, you ask them to have a buddy with them. Like if they're walking on roads, they are supposed to take some precautions. So this we tell even for a normal child to do. So no other special restrictions you're not going to put for a child with first seizures. And even prolonged seizures, like up to 30 minutes, the seizures studies have shown does not cause much of a brain damage unless it is associated with the underlying acute neurological insult. Okay, so as such, the seizures or a status may not cause a brain damage to the child. Okay, so this shows that only to prevent a second seizure, we are not supposed to start the child on AED. And psychological and psychosocial and pharmacological considerations. So psychosocial is very, very important. So if we are starting a child on AED, it means that we are branding a child as an epileptic. So epilepsy, although it is a disorder, it, in people perception, it's a disease. Okay, so any child who's having a chronic illness, the child itself will have a low self-esteem, and it is perceived to be a ill child by the relatives or even by the parents or even by the child's own self. And all these might affect the self-esteem of the child when they become an adolescent. And so adolescents usually have risk-taking behaviors, but we'll be putting on this. And the economic status of the family, that for long-term AEDs, the hospital visits. So a lot of things that we are supposed to consider while starting an AED, because starting an AED means at least 2 years we're going to put the child on the drug. And side effects of the drugs. So the 4 most common drugs that we use is the phenobarbital, phenytoin, valproate, and carbamazepine. So class 1 and class 2 studies have shown that they have clinically relevant cognitive and behavioral effects, and systemic side effects are seen from ranging from 7% to 58% in various studies. The common are rashes, hirsutism, weight gain, or nausea. So again, we'll have to consider. Okay, so after first unprovoked seizure, so we should think whether it is going to be a highly recurrent one, and whether why not have a second seizure, and what are the psychological and pharmacological things that we are supposed to consider. So we cannot give one individual guideline. It is always individualized, involving the patient and the parent in also the discussion before starting the drug. So AAN, American Academy of Neurology, it says that treatment with AED is not indicated for the prevention of development of epilepsy. Okay, so as such, So we are supposed to even tell the parents that starting a drug doesn't mean that they are not going to have another seizure at all. It just reduces the chances of occurrence of further seizures, but it does not guarantee elimination of further seizures at all. So it should not be started just only to prevent a second seizure. It may be considered in circumstances where the benefits of reducing the risk of second seizure outweigh the risk of the pharmacological and psychosocial side effects. And these are the choices of anti-epileptics that we have for the common seizure or epilepsy types. Like primary, we usually start valproate or a levetiracetam, and partial, usually a carbamazepine or an oxcarbamazepine. Absent epilepsy, again, we start with valproate. In BECTS, we prefer carbamazepine. If not, maybe a valproate. Juvenile myoclonic epilepsy, again, valproate or lamotrigine. Infantile spasm, ACTH, if it's a West syndrome, or vigabatrin, we choose as first line if it is a tuberous sclerosis. And Lennox-Gastaut syndrome, again, valproate or lamotrigine. And Dravet syndrome, we have multiple seizure types. So mostly we use valproate along with a clobazam or a clonazepam. And common drugs have many side effects. Okay, like phenobarbital, of course, with the cognitive, and phenytoin, the cosmetic side effects, and phenytoin, valproate, and carbamazepine, we should also, and even levetiracetam, the common drug that we use nowadays, also has some behavioral effects. So all these have to be considered before starting, and counseling for the same should be given to the parents also. So parent, it is even studies have shown that 1/3 of the mothers who witness the first seizure in a child has some post-traumatic stress disorder. So seeing a child experiencing a seizure is definitely a traumatic event for the parents. So we should try to allay their fears and always discuss with them the risk of recurrence, the side effect profile, and teach them about the precipitating factors for breakthrough seizures and how to avoid them. And the seizure diary should always be kept by the parents. And home management. So any seizures, usually more than 3 to 5 minutes, we should tell them how to use a rectal diazepam or a nasal midazolam. So when to stop? Okay, so when to stop itself is a big topic, but generally it depends on the etiology. Like in NCC, if it is an active lesion, we give till the disappearance, or 2 years if it is a calcified lesion. And juvenile myoclonic epilepsy, it may need a lifelong treatment because they are prone to get repeated episodes. But generally speaking, an adolescent onset, a remote symptomatic seizures, and the EEG persisting to be abnormal even after 2 years of seizure-free period, these are predictors of relapse. Maybe we should try after 2 more years. And withdrawal should never be sudden. You do it a slow tapering over 3 to 6 months. So if they're taking multiple drugs, you do one drug at a time. So finally, a general approach. If it is a first seizure, then rule out all the non-epileptic events by the history. And next, whether it is a provoked or a unprovoked, which we can see from history and basic investigations. So if no provocating factors identified, then if there are any focal deficits, it's a prolonged altered sensorium, then do a neuroimaging urgently. Any features suggestive of epilepsy syndrome, then start AEDs. Otherwise, assess the recurrence risk, like abnormal EEG or significant MRI findings or remote symptomatic seizures, again start AED. Otherwise, if the child experiences a second seizure, then start an AED. Okay, these are my references. Thank you, sir.
Thank you, Dr. Kanimozhi, for giving an excellent overview of an approach to the first episode of unprovoked seizure. And the session is now open for questions from the audience. Do we have any questions on the chat? You can also put questions in the chat box. Is it allowed, Dr. Ilamaran, if we can have some?
Dr. Allowed.
So I think there are no questions in the chat box.
So I have some questions.
Yeah.
I can? No.
Yeah, go ahead.
So for Rolandic epilepsy, what do we do? Because a lot of children come with nocturnal seizures and 1 episode, 2 episode. So should we start, or we'll wait for a few or 3 or 4 times?
No, so that is what Rolandic epilepsy is, again an epilepsy syndrome. Like if we have typical, actually Rolandic epilepsy, we can identify from the seizure episodes itself, or from the history itself, we can diagnose the BECTS. the typical age of onset, the nighttime seizures, the aura sometimes they have. And if we have a typical age also, then even with one seizure episode, we can start medications. For Rolandic epilepsy, it can be a valproate or a carbamazepine. And even in Rolandic epilepsies, they require treatment for a longer duration sometimes, not just 2 years, but sometimes they require longer duration. It depends on the response. But usually they outgrow the seizures when they grow up, when they become adults.
Yeah, I think that's right. So that's why I think Dr. Elomaran wanted to know, because in one slide you said you need to outweigh the balance and risk before we start therapy. Yes. We know this is a benign seizure and usually children outgrow. And yeah, so sometimes it is also okay to just wait and watch if the seizures are not very long, like if it's not more than 5 minutes, or if it's not associated with any abnormalities in the vitals. Some people would also wait and watch if it is benign epilepsy with centrotemporal spikes or Rolandic epilepsy. Yeah.
So nice presentation, Dr. Dr. Venkatesh, just one important point I just want to share.
Yeah, sure.
There has been a child who was diagnosed as Rolandic epilepsy and started on valproate for abnormal EEG. But then these episodes were continuing. So just going back by history, by examination and all that, the diagnosis itself was entirely different. One which I had published. It was actually a polyp which was causing obstructive sleep apnea. That was causing kind of abnormal movements, seizure-like episodes, grunting movements. Because when we say nocturnal grunting movements, we think of epilepsy. So it was actually an obstructive sleep apnea, which was masquerading as a Rolandic epilepsy. So again, our role of history and examination, because the child opened the mouth, there was a polyp coming out of the oral cavity.
Yeah, that's interesting. Yeah, but I think like what Kanimozhi